We are live, we can start.
Thank you. Good evening, everyone. A warm welcome to all of you here today, joining us from across India. My name is Dr. Prashant Subramanian, the Medical Director, Emerging Asia and India at Abbott Diabetes Care. This is a series of webinars focused on continuous glucose monitoring, and this is under the guidance of the RSSDI, or the Research Society for the Study of Diabetes in India. This is a fourth event, and we are fortunate that the RSSDI has agreed to accord CME points specific to this, and you would get, as long as you've attended all of the webinars, and you would get a certificate of having participated in the series of webinars. So for today, we have a very interesting topic to delve into all of the details specific to continuous glucose monitoring. We have a wonderful speaker today, Dr. Shalini Jaggi, who's a consultant and director, Life Care Diabetes Center, New Delhi. She's a fellowship from the Royal College of Physicians of London, both in diabetes and in endocrinology. She sits on the governing committee at DIPSI. She's the secretary of the RSSDI Delhi chapter, the serving ACE advisory board member, member of the RSSDI National Task Force on Women and Diabetes, and ex-National Executive Council member of the RSSDI. She's been the recipient of various awards at all of these esteemed platforms. She's a faculty and tutor at the Cardiff University, UK, and University of South Wales, UK. She sits on advisory boards of Women's Interprofessional Network of the American Diabetes Association, and has numerous publications, 50 and above, in reputed national and international scientific journals, and more than 40 chapters in textbooks. For the session today, before I hand over the proceedings to the speaker, a kind request to jot in your queries in the chat function or the Q&A section. We wish to collate all of them towards the Q&A session after the presentation by Dr. Shalini Jaggi. We hope you would jot on all of your questions during the presentation to ensure that all of your queries are addressed by the speaker, Dr. Shalini Jaggi. I hand over now to the presentation.
Thank you so much, Dr. Prashant, for that warm introduction, and I hope we get a lot of discussion once we finish with this presentation. I'm Dr. Shalini Jaggi, consultant diabetologist at Life Care Diabetes Center, Kirtinagar, New Delhi, and I'm also the current secretary of RSSDI Delhi chapter. So this module that I'm going to talk today is part of the Project Outreach, a collaborative effort between RSSDI and Abbott on increasing awareness on use of continuous glucose monitoring in our country amongst physicians, diabetologists, and endocrinologists. Now, technology has changed the way we manage our patients, and continuous glucose monitoring has opened up new arenas when it comes to actually reducing the number of pinpricks and making life much easier for our patients with type 1 and type 2 diabetes. So the job assigned to me today is on evaluating the clinical trial data with continuous glucose monitoring and its implications in clinical practice. Just for a quick recap, we know that in the previous modules, my previous speakers, Dr. Unni Krishnan, as well as Dr. Jyoti Dev, introduced you to the basics of CGM, what the entire technology is all about. Dr. Banshi also talked about the recommendations, the international as well as national recommendations on use of CGM. So the components of a standardized CGM report have been discussed. How to interpret AGP curves has been covered, besides the rationale for a 14-day AGP. And the previous speakers also covered professional as well as patient-led CGM in clinical practice and how to start with CGM. Now, this is an era of evidence-based medicine. So I think all of us need the evidences that go not only in influencing the way we practice, but also the recommendations that we always talk about. So what I am going to do today is bring to you the clinical evidence for the role of sensing technology in type 1 as well as type 2 diabetes. We'll talk about the real world data regarding sensor-based monitoring coming from India, which is very, very relevant to the kind of patients that you and I see. We will also have a small case discussion on how we can initiate CGM in a person with diabetes. And I'll finish by telling you how to transition patients from SMBG to sensor-based glucose monitoring. So let's first look at all the clinical evidence that we have on use of sensor-based glucose monitoring in patients with type 1 as well as type 2 diabetes. As you can see, this is a busy slide, different color codings on different studies. The purple is for clinical trials that we have on different aspects of CGM use and its benefits that have been studied both in patients with type 1 as well as type 2 diabetes who were managed with multiple daily insulin injections. The blue coding is for meta-analysis that have been published, and green is the whole gamut of real-world evidence that we have from across the globe on how CGM improves glucose control and outcomes in patients with type 1 diabetes as well as type 2 diabetes who are on multiple insulin injections. So you can clearly see we have clinical trials as well as meta-analysis and real-world evidence when it comes to reduction in HbA1c when we use CGM for our patients. Again, you can see here a marked reduction in hypoglycemia, an improvement in time in range, reduced hospitalizations, all in terms of acute events, as well as diabetes-related hospitalizations and all-cause hospitalizations coming down when CGM is used in our patients with type 1 and type 2 diabetes who are already on multiple insulin injections. We have a number of trials when it comes to improvement in quality of life and satisfaction. You have the selfie study, the impact study in type 1 patients, Flash UK, you have replace, you have all these different studies in type 1s as well as type 2 diabetes, different studies showing you how when CGM improves glycemic control, not only are all these parameters improving, but the overall satisfaction rates and the quality of life of our patients improves. And this eventually translates into reduced absenteeism from work. So you have all these different studies that actually are actual data convincing us on how CGM has revolutionized the way we are monitoring and treating our patients. Again, there is a lot of evidence which demonstrates that CGM improves outcomes in patients with type 2 diabetes who are even on basal insulin or even on non-insulin therapies. So as you can see here, you have all these studies, the Vada et al., Carlson, Wright, Miller, Elliott et al., and the Carlson et al. Studies clearly showing a reduction in HbA1c when CGM is used. You have studies showing an improvement in the time in range, evidence on reduction in hospitalizations, evidence on improvement in quality of life when it comes to patients with type 2 diabetes, even on non-insulin therapies. This is the impact study, a 6-month randomized controlled trial of 328 patients with well-controlled type 1 diabetes, that means an A1C of less than 7.5%, where CGM helps us reduce the time in hypoglycemia and increases the time in target range versus blood glucose monitoring. So as you can see on your screen here, in these well-controlled type 1 patients, the impact study clearly shows a 38% reduction in the time spent in hypoglycemia, a 40% reduction in time spent in nocturnal hypoglycemia, and an extra 1 hour added to time in range in these patients with type 1 diabetes. Moving on, let's look at some more evidence when it comes to patients with type 2 diabetes. Here again, this is the REPLACE study, a 6-month randomized controlled trial of 224 patients with type 2 diabetes who were on intensive insulin therapy. And this is a study that clearly shows marked reduction in hypoglycemia compared to SMBG. So you can see a 43% reduced time spent in hypoglycemia, a 54% reduced time spent in nocturnal hypoglycemia, and a 53% reduction in time in serious hypoglycemia in these patients on intensive insulin therapy. These are patients with type 2 diabetes. So again, CGM clearly showing not only good glucose control, but marked reduction in hypoglycemia, both in type 1 as well as type 2 patients. Now, this is the FLASH UK study. This is a 24-weeks open label randomized parallel design study of CGM2 system versus the blood glucose monitoring control group. 156 participants were more than 16 years of age. This was again study in type 1 diabetes patients. wherein you can clearly see that patients who were on CGM versus patients on self-monitoring or blood glucose monitoring with finger stick, this study clearly showed a reduction of 0.5% in the CGM group versus the blood glucose monitoring group, an improvement in 130 minutes per day in time in range, 43 minutes per day less time in hypoglycemia, and again you see time in serious hyperglycemia reduced by 86 minutes per day in patients on CGM versus patients who were on fingerstick glucose monitoring. So again, Flash UK goes on to tell you how all these parameters get improved if your patient is switched from blood glucose monitoring with fingerstick versus the CGM. This is the selfie study in children and teenagers with type 1 diabetes, where CGM is associated with significant improvements in glycemic control. So you can clearly see here the overall satisfaction as assessed by the diabetes treatment satisfaction questionnaire clearly shows that even in children and teenagers, when CGM is used in these teenagers and children with type 1 diabetes, clearly the time in range improves, time in hyperglycemia comes down, eventually translating into a 0.4% added reduction in HbA1c. This is 2019 study in patients with type 2 diabetes on multiple daily insulin injections, where CGM demonstrated significant improvement in HbA1c with much better, much higher patient satisfaction. You can see an HbA1c reduction from baseline to 0.82% reduction in 10 weeks versus the blood glucose monitoring group, where you see only a 0.33% reduction in HbA1c. And of course, compared to BGM, patients using CGM scored higher, both in terms of flexibility as well as in willingness to recommend this technology to others. Because obviously, the perceived frequency of hypoglycemia improved significantly in the CGM group versus the blood glucose monitoring group. So, of course, the study goes on to conclude that more patients using the CGM system had more than 1% HbA1c reduction by week 10 versus the blood glucose monitoring group, and the frequency of hypoglycemia actually did not differ significantly between the two groups, so much better satisfaction indices here. This is the Vada et al. Study published in 2020 in people with type 2 diabetes who are not using insulin. Again, you can see a marked improvement in glycemic control when CGM technology is used, and this is sustained at 24 weeks. So you can see a reduction in HbA1c from baseline in the BGM group versus the CGM. So this is the patients, the blood glucose monitoring group using fingerstick technology versus the continuous glucose monitoring technology, and you can see a much better reduction in HbA1c even at 12 weeks, and a similar reduction is sustained even at 24 weeks. So CGM technology actually enables these patients to preserve their good glycemic control even after the device was discontinued. So that's the beauty of using this technology. Now moving on, this is a meta-analysis by Mark Evans et al. Of real-world studies that have demonstrated an improved glycemic control with CGM in adults with type 1 as well as type 2 diabetes. So you can see adults with type 1 diabetes having a much better change in HbA1c from baseline in 3 to 4 months as well as 4.5 to 7.5 months, and again similar reductions in even adults with type 2 diabetes. So clearly we know that a higher baseline HbA1c is associated with a greater HbA1c reduction, and this meta-analysis actually showed a longitudinal analysis demonstrating that reductions in HbA1c were sustained for 24 months in people with type 1 diabetes and for at least a year in patients with type 2 diabetes. So again, you see improved glycemic control when CGM technology is used in both patients with type 1 as well as type 2 diabetes. Now moving on, one important part is scanning. How often do our patients scan when they are using CGM technology? We all know that the minimum mandatory scanning is about 3 scans in a day, 8 hours apart. But this is a study by Lang et al., a real-world study in both patients with type 1 as well as type 2 diabetes, which shows that if your patients are scanning frequently, it further translates into more time in range. So as you can see here in this graph, the green line is the number of scans, and this blue curve is the reduction in A1C, the estimated A1C. What it clearly shows is for patients who do minimum scans, which is like 3.5 scans in a day, versus patients who do a lot of frequent scanning, almost 38.5 scans in a day. You can clearly see that higher the rate of scanning, more the frequency of scanning, you see that the estimated A1C reduced from 8.2% in the minimum scanning group to 6.7% in the maximum scanning group. Again, the time in range increased by 43% from 11.7 hours per day to 16.8 hours per day in patients who were doing frequent scans. The time below range, that means the hypoglycemia, also came down by 26% in patients who were doing more scans versus patients who were doing less scans. And the hyperglycemia time above 240 further reduced by 63%. That means from 5.9 to 2.2 hours per day in patients who were doing more scans. So the study beautifully went on to conclude that an increased frequency of scanning is associated with improvements in glycemic measures, including a decreased mean glucose and an improvement in the time in range. So that is why we always say that once you have a patient on CGM, the best utility of the CGM is if your patient is able to scan frequently and accordingly make modifications to his current management strategy, his diet, his lifestyle, etc. Now, this is 2-year data from Relief study, a very important study which clearly goes on to look at the use of CGM and whether it actually reduces hospitalizations for acute events in patients with type 1 and type 2 diabetes and the higher long-term persistence with CGM. So here you see on your left side, the type 1 diabetes patients, almost 31,000 plus cohort, and a cohort of type 2 patients, more than 41,000 patients. The green bar is the annual proportion of hospitalizations prior to CGM. The light blue is 1 year after CGM use and dark blue is 2 years after CGM use. What this clearly shows in both type 1 and type 2 patients is if you look at the causes of acute hospitalizations in your patients with diabetes in terms of diabetic ketoacidosis or hypoglycemia or a diabetic coma or simply hyperglycemia, you can see that prior to CGM use, the incidence rates were much higher. But as the patients start using CGM, 1 year down the line and further 2 years down the line, you can see a marked reduction in the hospitalizations for all these causes. Reduction in hospitalizations due to diabetic ketoacidosis, reductions in terms of hypoglycemia, again, marked reductions in terms of diabetic coma and hyperglycemias. Further on, this study also went on to show that at 2 years, people using CGM demonstrated a much higher persistence of almost 88% with this technology, and an estimated mean consumption of the blood glucose monitoring test strips was reduced by 82% and 84% in patients with type 1 as well as type 2 diabetes respectively. So clearly showing how CGM technology is so well accepted by the patients and they are happy persisting on this because of all the improvements and the convenience and the flexibility that CGM offers. So friends, sensor-based glucose monitoring is associated with better outcomes in terms of an increased time in range, reduced hypoglycemia, decreased A1C, improvement in the quality of life, decreased hospital admissions, and of course, decreased work absenteeism. So all the benefits why patients can benefit from this technology. Now, all that I showed you till now was the randomized trials, the meta-analysis, and the real-world studies from the West. Do we have data from India? I'm happy to say yes, we have a lot of clinical evidence with sensor-based glucose monitoring. So I'm going to take you through a few important real-world data that have emerged from India on these technologies. So this is data by Dr. Jyoti Dev's group on the clinical utility of professional CGM in patients with type 2 diabetes. You can see here 500 patients with type 2 diabetes were evaluated at 6 months of undergoing the flash glucose monitoring, and they were compared with a matched control group who received routine treatment and care device. So they were asked on a number of questions: cost effectiveness of the procedure, willingness, whether they wanted to continue it with it again, whether it was helpful in improving their quality of life, whether they felt that the clinician-patient interaction improved and was more productive, how did they feel, whether it was a painless sensor management, how was the glycemic profile, was it easy to interpret the reports, and whether it was discreet and convenient to use. And based on the patient responses, majority of the patients reported that sensor insertion was a painless procedure and had very positive comments and positive experiences with professional CGM use. Patients were willing to use the professional CGM again because of the perceived simplicity, its painless nature, increase in quality of life, and lower cost achievable with the device. So majority of the patients were very satisfied. The reported sensor insertion was painless and recounted positive experiences with professional CGM and were happy repeating it. Now, let me show you some more Indian data on association between professional CGM metrics and the risk of complications in type 2 diabetes. This is an analysis of 2 weeks of professional CGM use in 5,901 adult patients with type 2 diabetes. Three different profiles of glycemic variability were identified: the time in range profile, the hypoglycemia profile, and the hyperglycemia profile. Association of these profiles with existing complications was examined using the multinomial and logistic regression adjusted for HbA1c, sex, age at onset, and duration of diabetes. Compared with the time in range profile, both the hypoglycemia and the hyperglycemia profiles had higher odds of non-proliferative diabetic retinopathy, macroalbuminuria, and diabetic kidney disease. So clearly showing how hypoglycemia and hyperglycemia profiles show an increased risk of complications in patients with type 2 diabetes. You can clearly see a relation there. Also, the hypoglycemia profile had higher odds of proliferative diabetic retinopathy. So clearly, the distinct profiles of intraday glycemic variability are associated with different clinical profiles and odds of prevalent complications. Now, this is another study by Dr. Mohan's group, Anjana et al., looking at the effect of professional CGM use on A1C in patients with type 1 and type 2 diabetes. Clinical and biochemical data was obtained from more than 5,000 patients with diabetes with an A1C of more than 7%. Half of these patients were initiated on flash glucose monitoring based AGP with professional CGM, who were called cases. And half of these patients, the age, gender, A1C, site, and time matched controls, who were not initiated on AGP. So these were the control arm. What the study clearly showed was that the magnitude of reduction in A1C was higher among the cases versus the controls. The absolute difference in the A1C reduction between cases and controls was higher among patients with type 1 diabetes, 0.5% versus 0.2. Reduction in glycemic parameters was irrespective of the age or gender, and patients who did not use AGP had a 1.42 higher risk of not achieving even a 0.1% reduction in A1C compared to those who were initiated on AGP. So clearly, the flash glucose monitoring based AGP with professional CGM was associated with significant reductions in A1C levels both in patients with type 1 as well as type 2 diabetes. Now moving on, let us look at some Indian data on the effect of professional CGM use on A1C in type 2 diabetes. Now here, this is a study by Dr. Banshi Sabu's group looking at the glycemic variability and control in 108 patients with type 2 diabetes who had an HbA1c between 7.5 to 8.5%. CGM was used for 14 days. Patients were followed up on the 3rd day, 7th day, 11th day, and the 14th day. And of course, based on the follow-up on each of these days, as and when required, dietary or treatment changes were done as needed to get a better control. So, clinically relevant hyperglycemia was observed in 35.2% of patients and frequent hypoglycemia was seen in 53.7% patients. 91% of the patients actually had therapy changes, while the rest had only diet and lifestyle modifications. And you can see that the estimated A1C from the first to the last follow-up visit reduced from 7.96% to 7%. So use of Pro CGM reduced the HbA1c levels by 0.9% over that immediate 2-week period, the estimated A1c calculation, by identifying glycemic variability and enabling a suitable treatment as well as dietary changes. Moving on to some more data, these are the AGP curves, and I think this has been discussed by the previous speakers on how you have a median curve and then you have the interquartile range, which is the 25th and the 75th percentile, and then you have the outliers. So glycemic variability curves help in recognizing and treating the mass or asymptomatic hypoglycemic events. So the thinner the curve, the better it is, the less is the glycemic variability, and better is the glycemic control and improved time in range. Now let us look at some more data on the effect of pro-CGM use on time in range in patients with type 2 diabetes. This is a retrospective analysis of 105 adults with type 2 diabetes, A1C more than 7% on non-insulin diabetes agents and or insulin. Individuals were evaluated over 3 visits with 14 days use of the professional CGM. Glucose target range was set at between 70 to 180 milligrams per deciliter, and patients' the analysis included the pre and post daily average glucose, the time in range, time above range, and the time below range. So at the first visit, a CGM sensor was placed and patients were asked to keep a food log while being on this CGM. Within a week, the second visit was executed, where an interim analysis of pro-CGM and diet treatment modifications was made if required. And the last visit on day 14, the third visit, was when the CGM was re-evaluated to assess the degree of glycemic control. So as you can see here, when it comes to time in range, you can see between the baseline visit when the sensor was initiated and the 14th day visit when the CGM was completed, you see an improvement in the daily average glucose. From 191, it comes down to 137.4. Time above range comes down from almost 52% in the beginning to 18% towards the end. The time below range, that means the hypoglycemias, improve from 5.7% in the beginning to 1.5% at the end of day 14. And the time in range shows a massive dramatic improvements from 42% at baseline to 80% at visit 3. So pro-CGM clearly improves a daily average glucose and the amount of time in range over this 14-day period. Further on, if you look at the recurrent hypoglycemias, you can clearly see the average glucose improving in this group. You see the time above range coming down, the time below range, the hypoglycemias show a dramatic improvement from 21.1% time below range to 1.9%. So you see that in patients with recurrent hypoglycemia, 25.7% of these patients, the average baseline time below range significantly reduces from 21% to almost 1.9%. As a result, the time in range improves from 65% to almost 86% in these patients. So with that, all this evidence that I showed you the clinical trials, I showed you the meta-analysis, and I showed you the real-world evidence right from the West to the Indian evidence. Let us now discuss a simple patient case on how we can transition our patients from SMBG to sensor-based glucose monitoring. Now, this is Mr. Kapoor, a 38-year-old businessman, married with 2 kids, BMI 24.5 kilograms per meter square. He's been type 2 diabetic for the last 8 years and has a strong family history. Both his parents have diabetes. He's pretty well compliant on his medications and is currently on an FDC of sitagliptin plus metformin 50 by 1000 twice a day. He's on empagliflozin 10 milligrams once a day along with glimepiride 2 milligrams twice a day. Now, he checks his fasting glucose every other day but does not really get time to do most of his other post meals. Usually once coming back from office, he does a random glucose which comes in the range of 160 to 180. And most of his readings, fastings are between 120 to 160. So he's pretty assured that his glucose level is not bad as per his standards. So when he goes for an HbA1c test, he's surprised to see an HbA1c of 12.5%. Now, obviously, this is one patient who is quite surprised why his numbers are not really matching with his HbA1c. So this is where instead of SMBG, we try to use a CGM sensor for 2 weeks and ask him to follow up to see what his curves look like. And much to our surprise, this is what his ambulatory glucose profile looks after 14 days of sensor use. You can clearly see most of the glucose levels are above range. You see a lot of glycemic variability here. It's all over the place. So this is the reason why you can see here every day, his daily profiles, you see all the highs and the lows coming in. Most of the times you will see his glucose levels are spiking and then coming down. So this is what opens his eyes, and now he fully understands why his HbA1c is 12.5%. So obviously, what we do is make changes to his therapy. We stop the sulfonylurea and put him on insulin. We start on a co-formulation of idegespart because his HbA1c is already 12.5%. Of course, we continue with the sitagliptin, metformin, and the empagliflozin that he's taking. We teach him insulin dose titration based on his glucose levels. And of course, we also explain that probably he may even need to take a night shot of idegespart for intensification to achieve his target goals. So this was one case I simply put in here to clearly show you how sometimes when a patient is not doing too much of SMBG, or sometimes even if he's doing it dedicatedly, this gentleman was almost doing his fasting and his randoms on and off. But sometimes, of course, the HbA1c numbers do not match with the SMBG, and you have all these hidden gaps which can easily be deciphered if the patient is put on a continuous glucose monitoring. So friends, let us look at how we can transition patients from SMBG to sensor-based glucose monitoring. Of course, when it comes to initiating continuous glucose monitoring, you need to keep in mind that the success depends on your patient selection of what kind of continuous glucose monitoring is your patient fit for. Is he somebody who understands, who can actually the real-time scan HbA1c, or is it somebody you just want to put a professional CGM and send him home and call him back in 15 days? So it's important that we do a shared decision making with our patients, guide them on assessing which system best meets their needs and preferences. And of course, it's important to look at the cost, because unfortunately in our country, most of the cost is borne by the patient himself. You need to look at the insurance coverage that this patient has. Look at the level of his motivation to actually do continuous glucose monitoring. If he's somebody who really wants to play around, understand his diabetes, wants to make changes to his lifestyle, diet. So for him, obviously a real-time CGM and intermittently scanned CGM is definitely the CGM of choice. Somebody who does not have that level of motivation, sometimes your patient says he gets psyched if he's continuously monitoring. So for him, simply a pro CGM is much better. You need to look at his social support system as well as, of course, his manual dexterity and his intelligence to decide what kind of CGM would benefit this patient most. So when we decide to transition your patient off self-monitoring to the CGM system, it's important that we go in steps. So number one, of course, is inserting the sensor. So after insertion of the sensor, you need to motivate the patient to scan frequently for a week and probably discuss these readings with the care clinic to determine if the treatment regime is effective. Use the ambulatory glucose profiling report to identify the problematic glycemic patterns and suggest necessary therapy adjustments, which could be adjustments in his doses, which could be adjustments in his diet, which could be changes in his lifestyle. Of course, we need to motivate the patient to scan frequently, because it's important that they keep scanning frequently so that they can actually see whether the changes that are being made are actually translating into some benefit. And of course, it has to be a collaboration. So ask the patient to return to the clinic at the end of the week for a collaborative discussion with the clinician to evaluate the use of the CGM system. So who are the patient groups where CGM proves to be very, very beneficial? Where can you suggest this? Where can you use it? Of course, any patient with diabetes, it could be a type 2 patient on non-insulin therapy. It could be a patient with type 2 diabetes on an intensive insulin regime. It could be a type 1 diabetic, of course, who has to adjust his insulin doses. And of course, even in patients with type 2 diabetes who have low numeracy skills, there also sometimes we can really make benefit if we use CGM to establish the fixed meal insulin dosing. So few practical tips that you can use during your patient consults when we're talking about CGM is educate the patient prior to initiation of CGM, which is very, very important, because you need to make them aware of what exactly this technology is all about. Let them see the device, let them understand the device and any troubleshooting that may be required. Of course, it is important that we explain the different views that the patient can see on the reader device so as to clear any apprehensions they may have, explain each of those profiles to them. We need to spend some time and explain so that they can make maximum use of all the benefits, all the different views that you can get on the reader. Of course, don't overload the patient. That can sometimes be very apprehensive. For an apprehensive patient, it could be really counterproductive. So I think we need to cover things in steps, cover them slowly, and explain important points to the patient. It's important to manage the clinic workflow to ensure that the patient is aware of the things to do before he comes for the next consult. So of course, when you are talking about CGM and initiating a CGM, maybe at that first review, you need some more time to be spent with that patient. So dedicate that time with the patient. Maybe one of your assistants can help you with that. So in subsequent reviews, they will be shorter as the patient will eventually understand the graphs and the trends. So also you need to explain the physiological lag time between the interstitial fluid glucose and the capillary blood, the necessity to rely on glucometer readings during episodes of hypoglycemia, which needs to be emphasized. So the best practice is to minimize the number of distress calls at night. So it's very important that we have this conversation, educate the patient on CGM and set realistic targets. CGM liberates a patient from the hassles of glucose monitoring. So it's important that you introduce your patient to what the sensor looks like. It is easy to apply. It's comfortable to wear for 14 days. Patient can easily have his bath. It's absolutely waterproof. It is a small and discreet disc, which is almost comparable to a small coin. And of course, there is no need to do a finger prick calibration with these sensors. Reader is again something the size of a small glucometer, scans over the clothing within 4 centimeters, and provides up to 8 hours of glucose history, trend arrows, patient-friendly graphs, and stores 90 days of glucose data. So it's very important that we introduce the patient to all these things before we actually put the patient on sensor so that he understands what he is getting into. Now, this is a sample AGP report which clearly reveals daily trends and time in range and allows clinicians to make informed therapy decisions. So you can see here in this corner, the average glucose and the glucose management indicator statistic closely aligning with the A1C levels. Then, of course, it shows you the time in range. You see this bar, which clearly shows a target range that is set for the patient. Usually we set 70 to 180. And then the yellow and the orange showing the time above range, so glucose levels going up, or the time below range shown in red, which is the hypoglycemia. Furthermore, the glucose profile and daily profiles allow you to identify trends and patterns and the problem areas. And minimizing hypoglycemia is the first goal of therapy, targeting less than 4% of time spent less than 70 and less than 1% of time spent less than 54. So this is how you interpret an AGP report. So friends, before I conclude my key takeaways from this module, sensor-based glucose monitoring overcomes the limitations that are associated with the A1C test while providing actionable insights for improving glycemic control. The ADA standards of care since 2020 has recommended A1C in conjunction with a continuous glucose monitoring system and the use of standardized reporting that include time in ranges. A growing body of clinical evidence supports the use of sensor-based glucose monitoring in type 1 and type 2 diabetes patients on insulin. The key benefits include improvement in time in range, A1C, hypoglycemia, hospitalization, work absenteeism, and the quality of life. And getting patients started on an appropriate monitoring system is best achieved through collaboration and shared decision making. So friends, with that, we conclude this presentation. I hope the module has been clear, and I'm happy if you can put your questions in the chat box and we can take them up for discussion. Thank you so much. Hello, friends. I'm Dr. Shalini.
Thank you, Dr. Shalini. That was fantastic. A crisp summary of the evidence, the meta-analysis, as well as real-world evidence before you delved into the patient case, as well as practical tips. There are a few questions already in the chat function, but before we get there, most common question would be switching between BGM to CGM. So there was a slide on practical tips. So how do you do it in your routine practice? So there's more in terms of patient walking in or the practical things that you've already planned before you have a consult.
Well, if you ask me, what I do is on my desktop screen, I have a few sample AGP reports saved, So there's one on glycemic variability. There's one on what a very good graph looks like. There's one on how the ups and the downs go. So I think when I see the need of a continuous glucose monitoring in a patient, all I need to do is explain what the technology is all about, how it differs from the point to point finger stick. A patient may be very well motivated and doing almost 3 to 4 tests in a day. I'm not saying all patients don't do it. There are a few set of patients who do it diligently and religiously. So when for them also sometimes you see a discrepancy between that point to point reading and an HbA1c, and they end up all confused. It's like my readings are pretty good, but then why is my A1c bad? Like that sample patient I showed you. So for them, a 120 or a 140 or a 160 at time, maybe all that he's doing is doing the pre meals, and he's just not done his post meals where you see those spikes. So I think that is where this continuous glucose monitoring fills the gap. So somebody who's probably having nocturnal hypoglycemia, maybe an asymptomatic hypoglycemia in his sleep, and he wakes up with a higher fasting. So that is where you see those hidden curves. So it kind of connects the dots. So I think once you show all that to the patient, it makes them much more motivated, because then they want to exactly find out what is happening throughout the day and even in sleep. So I think it's more important to show the patient how it is going to help them rather than just talking about the device. Once you show them, this is how I'm going to get your graph, and I will actually know, and you will also get to know how your glucose levels vary the entire day, whether just doing a fasting is not sufficient. Many patients religiously wake up in the morning and do a fasting. That's the first thing they do. So they're like, I check my sugars every day, but all that they're checking is a fasting, and then they're surprised why the A1c doesn't match. So I think what you need to do is have a discussion with them, tell them what this is about, how this connects the dots and the things that we do not really see in those SMBG charts. So all the hidden things come out very clearly. So that's where you need to have a conversation.
Thank you, Dr. Shalini. A connected question here. So there's a question about the use of CGM in patients who are only on basal insulin. So no prandial, just basal insulin without OADs. So specific to clinical trials, I can assure the audience there's real world data both from the US as well as the most recent one from France, where they followed up with 5,000 odd patients looking at hospitalization. So there was a 75% reduction in the risk of diabetes ketoacidosis hospitalizations, as well as a 44% reduction in the risk of severe hypoglycemia. That's the safety aspect. In terms of the efficacy from Canada and US, there was a 1.1% reduction in A1C from a baseline of 9.1. So pretty high A1C, but there were still benefits to be had. But Dr. Shalini, over to you. In the eye of the expert, if you've used this in patients on basal insulin, and where would you put this in terms of the choice in such patients?
Absolutely. I think immaterial of the therapy that you are using for your patient, an AGP always helps. Be it somebody who's on simply oral drugs, be it somebody who's on an oral plus basal regime, or somebody who is on an intensive insulin regime. So what AGP is actually doing is showing you all that we did not know. An SMBG, like I said, for somebody who's on a basal insulin, maybe what you tell them is to check a fasting and titrate the doses based on the fasting glucose. That's the common algorithm that we follow when you initiate a basal insulin. And once the fastings are on target, they're checking their postprandials, or maybe a post lunch or a post dinner. So for those patients who are just doing 1 or 2 odd glucose levels, I think a CGM really tells them whether there is some glycemic variability, whether the glucose levels are in range all day, or whether they're getting hypoglycemias or maybe hyperglycemic excursions. So I think immaterial of the therapy that is being prescribed to your patient, it helps in connecting the dots. So even if it is somebody who's on a basal insulin, somebody who's on simply oral drugs, it definitely has its use. It's not a device only for people on intensive insulin. Sometimes people feel that, continuous glucose monitoring means intensive glucose monitoring reserved for patients on intensive insulin regimes. So I think that's wrong. It is for anybody and everybody who wants to exactly know the patterns of their glucose all day, all night, based on a standard living style that they have. These days we see a lot of people in social media who are using it, even non-diabetics, fitness freaks, people, putting those chips and trying to figure out what food suits them, what is causing spikes, are they getting any lows. So I think it's about anybody and everybody who wants to actually look at their glycemic patterns, who want to actually rule out glycemic variability, who want things on control. So I think it's for anybody and everybody, especially for patients with diabetes. Of course, it's a boon.
Thank you, Dr. Shalini. A related question in terms of um, the challenges that you've seen while having the conversation with patients and initiating CGM, and how do you circumvent them?
One challenge, of course, is the cost, because, like I said, a lot of people sometimes do not find it very comfortable spending that amount of money, because the sensors are obviously a little more expensive than an average Indian pocket for a normal middle class person. But when you calculate the cost of the number of strips used for even 6-point SMBG every day versus using a CGM, I think it's a better bet. So I think instead of looking at those immediate short-term cost, if you look at the long-term benefit that a patient gets out of interpreting and changing treatment pattern based on a CGM report, I think. So the long-term benefits in terms of reduced hypoglycemia, reduced hospitalizations, reduced complications, I think that kind of covers up for the cost benefit. Some patients, of course, like I said, there's this degree of patients who are a little more apprehensive and who really don't want to get obsessed all the time with their glucose levels. So there you need to kind of choose the device, like I said. For somebody who's very, very keen and very well motivated, simply intermittently scanned, a Libre is very good for them, because they can always keep scanning and looking at their glucose levels and probably deciding on whatever they want to eat or whatever insulin doses they want. But for others also, I think it's more important. I feel the challenge can easily be overcome if you have the right conversation with your patient, because you need to choose which patient suits best for which kind of continuous glucose monitoring that you want to initiate. If you are able to put forward the benefits of what exactly is the outcome you are looking for in this patient, why you want to initiate, if you are able to convince that patient, I don't think there's too much of a challenge. It is a simple device. Nobody from the outside can see it. It's just hidden under your cloth. And you don't really need to pull up your sleeve to actually scan, because like I said, you just have to put the scanner 4 centimeters and you can get the readings. So I think it's a very discreet and a very convenient device. Even patients feel that will it be painful. So I mean, kids are using it. So I think it's about how you convey and how you convince. Like I said, the talking part is very important. I think then all the challenges can easily be met.
Thank you, Dr. Shalini. The next question is somehow related. So this is again $1 million question for the research community. Intermittent use in type 2 of intermittent use CGM. So your take on it? Continuous use does have its benefits, but periodic use of CGM through the year, maybe 2-4 sensors. So how do you do it, and your best practical tips?
Well, it depends on the indication for CGM, the profile of the patient. There are some patients, especially a lot of kids with type 1, who are very tech savvy, who do not really want to do a lot of finger pricks. So for them, 15 days here and 15 days here is a norm now. So, when they come for a review, they'll come to you with those 15 plus 15 plus 15 plus 15, those kind of charts. So this is one set of patients who are doing it regularly and continuously and religiously, provided they can afford, of course. There's another set of patients who probably do it once in 3 or 4 months, where they just want to see whether everything is going right. So somebody who's probably not too much into SMBG, or somebody who does some amount of SMBG, comes to you with an A1C report, but just wants to see whether things are going right. There will be some patients who ask for it because they actually want to know what is happening to their glucose profiles. So I think, again, like I said, continuous versus intermittent is a shared decision making. Whether you feel that this patient needs it regularly, and if you can afford it, definitely, especially the intensive insulin regime patients. So there may be a continuous use, definitely, if they can afford it, helps. But for somebody who is not really on very intensive regimes, who's on simply oral drugs, or somebody who's getting maybe nocturnal hypoglycemia, somebody who's waking up with a high fasting glucose, or people where you cannot really correlate the SMBG readings with the HbA1c that you are getting. So those are places where intermittent use of CGM does help.
Thank you, Dr. Shalini. Speaking of situations, so there's a question related to gestational diabetes. This is more going back in terms of pathophysiology. So this is the exact question is, why is there false low A1C? Or I guess the interpretation is, why are the targets so low set for GDM versus patients with type 2 diabetes?
Of course, pregnancy, the physiology is completely different. In pregnancy, the whole idea is, this is more of a physiology question. And as it is in pregnancy, the glucose levels in a normal physiological pregnancies are much lower than a non-pregnant adult. So that's one thing. We're not even talking of gestational diabetes or a diabetic pregnancy. For a normal non-pregnant woman, her glucose levels in pregnancy are physiological lower, and that's because of the hormones. So if it is early pregnancy, it's the estrogens and progesterones that are going up, which cause beta cell hyperplasia. So there's a state of hyperinsulinemia that happens in early pregnancy, which drives the fasting plasma glucose low. So in a normal pregnancy, the fasting plasma glucose comes down by almost 10 to 11 compared to a non-pregnant woman. Similarly, in second and third trimester, what happens is the diabetogenic stress of the hormones, the HPL is going up, cortisol is going up, all the pregnancy hormones are coming in. So all those are basically diabetogenic. The adipocytokines are increasing. So all those things are going up. So as a result, if your beta cells are healthy, in a normal pregnant woman, there is a compensatory 200 to 250% increase in insulin secretion that happens to keep the blood glucose levels at normal. So this is again where the postprandial normal glucose are within about 120. There was a paper in Diabetes Care 2011, Hernandez et al., if I'm not wrong. So that was one paper which actually looked at the normal non-pregnant women, the physiological glucose levels, and they discovered that in a normal pregnancy, the fasting levels are almost 10 to 11 milligrams lower than non-pregnant levels. The postprandials rarely will cross 120. The meal excursion, the pre-meal versus the post-meal, the excursion is between 30 to 35 because of that massive compensatory hyperinsulinemia that occurs in pregnancy to keep the glucose levels normal. And if that fails, that is when a woman gets gestational diabetes. So if the beta cell compensation fails. So it is normal that in a normal physiological pregnancy, glucose levels will be on much lower than the non-pregnant levels. And that is why the targets are tighter. So the time in range would be 63 to 140 in pregnancy, be it type 1, be it type 2, be it gestational age, because that's the normal physiological normals that we talk of. And anything going beyond that, of course, we know would be gestational diabetes for somebody who does not have a history of diabetes. And if it is a type 1 or type 2, that is why the targets change. Somebody who's diabetic prior to pregnancy, there only during the time of preconception counseling, we tell them to look for an HbA1c of less than 6.5 before they conceive, because anything more than that is associated with congenital anomalies in early pregnancy. And all through pregnancy, we give them a target of keeping their glucose levels to an HbA1c of less than 6% if possible. We only relax it to 6.5 or even 7 if there is recurrent hypoglycemia in a type 1 who's on intensive insulin. So that is the amount of tight glycemic control. It's a tightrope walk in pregnancy to manage glucose levels. And that is, again, one indication where CGM really comes in. We have the concept study, which was type 1 diabetic pregnancies. So concept actually showed that all these, macrosomia comes down, the preterm births come down. So the pregnancy, that is where, if you want good outcomes, not only do you need to do SMBG, the indication today is to use CGM as an adjunct to SMBG in pregnancy. So ask them to do their glucose monitoring, but for the trends, because the postprandial spikes are directly linked to macrosomia. So I think that is again an indication for CGM where you need to prevent those postprandial spikes.
Thank you, Dr. Shalini. Pretty comprehensive data, I would say, for GDM. There are a few questions specific to groups of patients where CGM would benefit the most. I understand that there's more as the audience is newer. to understanding CGM. So your tips in terms of how do they start when they start adopting CGM into their practice, some easy patient profile that you would choose to start with, get to know the product, maybe build on understanding this more, understanding how we work with patients, and then to scale it up to complicated patients.
Patient profile would be A, of course, any patient with type 1 diabetes where intensive insulin is being used, they'll be on basal bolus regimes. Most, all type 1s have to be on basal bolus regimes. There's no two questions on that. So they need to regularly monitor their glucose levels frequently, especially before taking their insulin shots. So this is one indication where CGM is extremely helpful. Again, for patients with type 2 diabetes, any patient who's motivated enough and wants to look at his glucose profiles is most welcome to use this technology. But as a doctor, if you want to use it, again, somebody who's not doing too many of it, SMBGs, somebody who's coming to you with complications and you need to actually look at their complication profiles, why those complications are happening. If the SMBG numbers, like I said, are not matching the HbA1c. So again, that's an indication. Somebody who's got an irregular lifestyle, people have call center jobs, people are, awake in the night and sleeping in the day. So for those therapy adjustments for them, CGM comes in as a very handy device. So I think pregnancy, again, like I said, just to, look at the glycemic excursions, again, CGM comes in as a very handy device. So I think any patient with diabetes who actually wants to look at their profiles, or if you want to understand why certain things are mismatching, or you need a greater detail of his profile to actually customize the therapy to that patient, where you really want to hit the glycemic goal and get everything under control, not only simply a point to point fasting pp and an HbA1c, but that throughout you want to see that he's in range and to reduce complications, because the whole idea of managing diabetes for any patient is to reduce complications, micro and macrovascular, and improve quality of life. So this is one device which actually improves the quality of life, end of the day, full stop. And that is what we want for all our patients. So I think any patient who can make optimum use of CGM is most welcome to use it.
Thank you, Dr. Shalini. A few questions specific to what do you see in the future now that we have CGM and it's evolved over time. We moved from BGM to now CGM. Most of the guidelines now also do talk about CGM as being incorporated into practice. So where do you see the realm of glucose monitoring going in maybe 5 years down the line in your practices across?
Of course, I think very soon, see, one thing that obviously needs to be done is affordability for an average middle class person with diabetes, because all said and done, yes, sometimes price does become an issue for somebody who wants to use it regularly and continuously. And that is the reason why, in spite of being convinced of its utility, it is being used intermittently rather than continuously. So that's one thing. But when it comes to the future, maybe price on one side, I see a very bright future with technology, because technology has changed the way we've been treating our patients, especially after, I think, COVID, with teleconsultations and EMRs and everything coming to being. I think we're moving towards automated insulin pumps now. So that's like, the CGM device communicating with your pump, and then your pump actually deciding on the rates of insulin delivery and delivering insulin. So if your CGM tells you that there's a hypoglycemia, the pump shuts down, gives you alarms. Once the glucose levels are getting corrected, it again restarts, and we talk of bionic pancreas these days. So that's the future. So, bionic pancreas is an integrated system with the sensors, with the insulin delivery, with the glucagon delivery in the pump. So I think the future is beyond anybody's imagination. And I think devices, improvement in quality of life, less of finger pricks, more of patient convenience is the way forward.
Thank you, Dr. Shalini. There are a few more questions, but in the interest of time, we'll get those to you to get your responses to be cascaded across. It was fantastic having you here today. A lot of practical tips, and I'm sure the audience will appreciate how you made it so tangible for them to include CGM in their current practices. A huge thanks to you and for the time today and the wonderful presentation. Thanks to the organizers and thanks to the RSSDI. I hope the audience did benefit from this. Thank you all for your insightful participation, and we look forward to seeing you at the next event, which will be the communication will be out pretty soon. Thank you,
Thank
everyone,
you.
and have a wonderful evening ahead. Thank you.
Thank you so much. Thank you, Abbott, and thank you, RSSD. And I'm sure the audience would have definitely gone back wiser. And I hope the acceptability of CGM in our audience improves once these modules are done. Thank you.
Thank you. Thank you, Dr. Shalini. Thanks,
Thank you.
everyone.